etiological agents of neoplasia. We dealt with some of the chemical and radiation uh, agents, ultraviolet radiations, chemicals, occupational diseases, and some other radiations. Continuing that etiological factors, viral oncogenesis, we dealt with the mechanism of viral oncogenesis in the previous lecture. Here, just to revise that there are two types of viruses: RNA viruses and DNA viruses. RNA viruses, they are more notorious in causing cancers, and they actually replicate through a retroviral mechanism and through retroenzymes. While DNA viruses, they are less common in causing cancers. So in viruses, there are many tumors which have been identified as having a viral etiology. Viruses, they have vaccines against them. Most of the viruses, they have vaccines, and here we are taking an example of human papilloma virus. Human papilloma virus is one of the only cause of cervical cancer. It is a proven cause of cervical cancer. This was the entire research which got the Nobel Prize in, I think, 2009. Uh, Human papilloma virus can cause benign diseases, can cause intermediate linked diseases, and they can cause malignant diseases. So, cervical malignancy is related to one of the species of human papilloma viruses, which causes cervical squamous cell carcinoma. Ectocervix is having squamous epithelium. If there is a long-standing viral infection which is not treated, and the viral species is uh, the one which is causing the malignant change, then it may first develop into a hyperplastic epithelium, dysplastic, and then leading to a neoplasia. We have vaccines against human papilloma virus. So, a female having a recurrent human papilloma virus infection may be vaccinated against a number of species to prevent cancer. Cervical cancer is also having a screening program. Not in our country, unfortunately, but in the West, there is a screening program, and every female uh, after 30 years of age is screened for uh, cervical abnormality in the form of a pap smear, that is a papinocular smear. Papillocolo smear or a pap smear is actually the name. Pap is from a scientist, Papinoculo, who devised this staining mechanism or staining technique. It is actually the cervical smear. It is just a cervical smear which is taken, and if the cervical smear is normal, then every year the female is going to be screened for the cervical abnormality. But if there is any abnormality, so there is a follow up, and human papilloma virus or HPV testing is done. If it is a benign virus which causes benign disease, the virus is treated through antiviral therapy, and further screening is done. And if it is one of the strains producing malignancy, then further treatment is considered. So, human papilloma virus can cause changes in the cervix. Human papilloma virus can also uh, cause malignancies or benign tumors in the oral cavity, and the larynx, on the skin, even wherever there is stratified squamous epithelium. So, human papilloma virus is actually penetrating the stratified squamous epithelium and replicating there causing a viral disease. Other viruses are sometimes indirectly involved in causing cancer, like in HIV. HIV itself is not directly related to producing a cancer, but as the patient of HIV is linked to a decreased immune system or a decreased immunity, so the patient is prone to develop a number of viral, bacterial, or other microbial diseases. So Kaposi sarcoma is one of the intermediate types of vascular tumors produced in patients of HIV through a viral cause. Human, Kaposi sarcoma is not only caused in HIV or AIDS, it can also be produced in a normal or can be caused in a normal person. It depends upon the strain of the Kaposi sarcoma producing viruses which produce this tumor. So, whenever you have a Kaposi sarcoma, uh, in a patient, we have to screen that patient for HIV. Sometimes a patient may uh, develop a tumor, and that is the first presentation of HIV. So, as we did this in the last lecture, also that there is identification of viral specific nucleic acids on DNA and RNA testing. So that is why viruses are notorious for causing tumors uh, amongst all the other microbes. So viruses other than human papilloma virus, there are many other viruses. You have a table in your book. Just go through that table once, and you are also going to read more about the viral tumors in the respective chapters in your fourth year. Giving another example, that is Epstein-Barr virus. Epstein-Barr virus can cause four types of tumors in humans. One is Hodgkin's lymphoma, another is non-Hodgkin's lymphoma, another is Burkitt's lymphoma. Burkitt's lymphoma mostly occurs in children and is more prevalent in Africa, and nasopharyngeal carcinoma. Nasopharyngeal carcinoma is prevalent in Eastern Asia, like in Taiwan, Thailand, Burma, and China, because of the prevalence of Epstein-Barr virus. So Epstein-Barr virus cause infection in nasopharyngeal region and may lead to nasopharyngeal carcinoma. Nasopharyngeal carcinoma it is a malignant tumor, and it has two peaks, one in the young age and then in the old age. In case of bacteria, the only bacteria that causes cancer directly is Helicobacter pylori. Helicobacter pylori, as we did, can cause four diseases in the stomach. It is bacteria causing diseases in the stomach. So it may cause peptic disease, peptic ulcer, gastritis, and then two types of tumor. One is adenocarcinoma of the stomach, and then another is malt lymphoma of the stomach. That is mucosa-associated lymphoid tissue, and the tumor, which is a malignant tumor, is a lymphoma. So adenocarcinoma may occur in stomach because of the untreated or a long-standing Helicobacter pylori infection. Coming to other etiological agents, nutritional oncogenesis. You all know that low fiber diet can lead to colonic carcinoma, fatty diet can lead to breast cancer, and a number of other cancers also. Betel leaves, that is palm leaves, may lead to oral cancers and oral pharyngeal cancers. Antioxidants, they are important in uh, reducing the cancer risks. In cases of nutritional, Nicotinamides are also one of the factors, and they are produced in cases of smoked and coal burnt food. So diet is important. So a mixture of well balanced diet is important in reducing the risk for cancer. Alcohol, not directly causing cancer, but alcohol can cause cancer indirectly, like first causing a chronic alcoholic liver leading to cirrhotic uh, phase, and then it may lead to production of hepatocellular carcinoma. Hepatocellular carcinoma leads to hepatocellular carcinoma occurs in a cirrhotic liver or a chronic alcoholic liver. Overweight is another indirect etiology, so exercise is important. Other carcinogen in food include aflatoxin. Aflatoxin causes hepatic tumor, and aflatoxin is a fungus which is produced in stored food, mostly in stored nuts and in wheat, if it is stored in a damp place. So aflatoxin is hepatocellular carcinoma producing nutritional agent. Coming to hormonal oncogenesis, hormones can produce or can lead to hyperplasia, which is adaptation, as we did in the first chapter. Um Estrogen can lead to development of lobules and ducts in the breast in case of pregnancy and lactation. But in case of breast carcinoma, estrogen is one of the factors that first produces hyperplasia in a normal person or a normal female who is not pregnant or lactating, then may lead to dysplasia and ultimately a neoplasia. Same way in case of diethylstilbestol, it is one of another hormonal agent taken from outside or an external source that produces vaginal and uterine carcinoma. But in this case, an interesting fact is that if the mother is taking diethylstilbestol in pregnancy or before pregnancy, the child born, if the child is a female, she's going to develop a vaginal or a uterine carcinoma in a very young age. So it is not the mother who was taking the diethylstilbestol, but the baby born to that mother. If he was taking diethylstilbestol in pregnancy, the baby may develop vaginal or uterine carcinoma in a young age. However, vaginal and uterine carcinoma in a routine female or a normal female or a normal person is age related and is seen after 30 years of age. So, synthetic hormones are taken with precautions like hormonal therapy. After menopause, it is a very important aspect to follow the patient, and the dose is important because imbalance in the hormones may lead to carcinogenesis. So, hormonal therapy is always through a prescription. So hormone-dependent neoplasias include a prostatic neoplasia that uh, the cause is testosterone, and dihydrotestosterone is the causative agent that first leads to hyperplasia of the prostate. Not treated may lead to dysplasia and then neoplasia. Similarly, breast carcinoma. Um, in breast carcinoma, estrogen is important. That is why whenever a patient is diagnosed with breast carcinoma and a biopsy is taken, estrogen receptors are also studied, because if the carcinoma breast is estrogen positive, anti-estrogen therapy is given along with the chemotherapy. Same way in thyroid carcinoma, TSH levels are important, and that may lead to thyroid carcinoma. Genetic oncogenesis. Like there are certain associated inherited diseases which may lead to tumor formation. So, Mendelian inheritance that includes dominant or recessive. Some of not all the syndromes are associated with tumors, but some are, like familial colonic polyposis may lead to tumor, and that is one hereditary syndrome that is 100% fatal, because if it develops a tumor, the patient is going to die because of the tumor, not because of the polyps. So 100% a patient having familial polyposis coli, he or she is going to develop a tumor in some point in the life. So if a sibling is having uh, familial polyposis coli syndrome, other siblings are also screened, and prophylactically total colectomy is performed. And if you have a patient who is diagnosed for the first time having familial polyposis coli, the only treatment is total colectomy. Retinoblastoma and Wilms tumor, they are also related to RB gene, which are one of the tumor suppressor genes. So retinoblastomas and Wilms tumors, that is nephroblastoma, that both of them are pediatric age group tumors, and both of them are blastomas. You are not going to see them in the adult age. In the lower part of the slide, you may see some of the syndromes which may lead to malignant tumors. So, for example, a patient having multiple basal cell carcinomas on the skin, you must have a suspicion that this patient is having a nevoid basal cell carcinoma syndrome. Men, as you already know from your physiology, that is multiple endocrine neoplasm, and there are three types of men syndrome that includes multiple tumors in the pituitary, in the thyroid, in the kidney, and in the adrenal glands. So, neurofibromatosis again is neurofibromatosis again is hereditary disease, which is a benign skin tumor, uh, and it may lead to malignant tumor, that is peripheral malignant nerve sheath tumor, but it is something rare. Neurofibromatosis itself is a benign uh, tumor syndrome. But in case of neurofibromatosis type 2, we have certain other tumors in the body also, like schwannoma or like meningioma in the meninges. Both of them are benign tumors. So that means that hereditary syndromes may lead to benign tumors and may lead to malignant tumors. Neoplants occurring in relation to polygenic inheritance, that means that familial uh, colonic inheritance, we already did in one of our lectures, that sometimes you have a tumor occurring in every generation, and that is because of the polygenic inheritance. There are multiple mutant genes which are inherited from the mother. So, mother or father. So, in case of breast carcinoma, that can be familial. Colonic carcinoma can be familial. Ovarian or the brain tumors can be familial. Can be familial. They are not always familial. So screening for cancer is one of the safest thing to do. So like I gave you the example of pap smear. Above 30 years of age, every female is screened for pap smear. And in case of breast cancer, again, every female is screened for any abnormality in the breast above 30 years of age. So there are some avoidable risk factors, for example, food, for example, occupational hazards, for example, radiation, for example, viruses. So you may avoid the external factors that may lead to mutations. In case of our immune system or cancer immunity, because we said that tumors or a tumor cell is a foreign cell, the body is going to recognize it as a foreign cell. So our immune system is going to get activated against that tumor cells, and because the tumor is under no control and it is going to grow irrespective of the normal human body, so immune system is not enough to demolish that entire tumor. But there are evidences that immune system is part of the tumor, uh, and there are evidences that the immune system is activated against the tumor cells, and that is one uh, point that our chemotherapy against tumor is now uh, leading to immune therapy. So many immunological agents are now evolved to be given against certain cancers. So these are some of the evidences that the immune system is working against the tumor. So immune elements are accumulated in and around the tumors. And what are those immune elements? Those are lymphocytes, mainly lymphocytes. There are dendritic cells, and then there are B cells, which are producing certain antibodies. Certain malignancies shows an increased incidence in immune compromised hosts, like we did in AIDS. In a patient having AIDS, he or she is more prone to develop tumors because of the lower immune system. So cancers frequently elicit tumor-specific T cells and antibodies. So in an immunocompromised patient, the tumors are free to develop because there is no immune system acting against it. But in normal immunocompetent person, the immune system is going to act against the tumor initially. There are certain tumor antigens produced in tumors. So there are two groups, tumor specific antigen and tumor associated antigen. Tumor specific antigen is present on the tumor cells only, and tumor associated antigens are actually present on the normal cells, but they are exaggerated in the tumor developing from that particular cells. So tumor specific antigens and tumor associated antigens. Tumor specific antigens are products of mutant oncogenes and products of other mutant genes. That means that oncogenes, which are tumor suppressor genes or proto-oncogenes, and then there are other genes which are uh, mutant. So epigenetic uh, hypothesis or epigenetic theory. Overexpression or overexpression of the cellular proteins. There are tumor antigens produced by oncogenic viruses. Oncofetal antigens are tumor-specific antigens. Altered cell glycolipids and glycoproteins. So they are nothing but they are antigens like the normal antigens, but they are only produced whenever there is a tumor. You can never have any level in the blood in a normal person. While in case of tumor associated antigens, you have a normal minimum level of tumor associated antigen normally in a normal person. But if the level of these antigens is rising, that means that there is something fishy going on in the body. So tumor associated antigen, for example, CEA, carcinogenic embryonic antigen, it is raised in case of colonic cancer, but it is also present normally in the blood with negligible uh, amounts. So if the antigen they are higher in the blood, that means that there is something going on in that cell. They do not evolve any immune response, while tumor specific antigens they are going to evolve an antigenic response, and T cells are going to produce antibodies against them because they were never present in the first place, while tumor associated antigens they were present in the human body, but in a lower level, so no antibodies are produced against them. They are useful in diagnosis and in prognosis. Also, they may be a target for immunotherapy, as I told you before. Both the antigens, tumor associated or tumor specific antigens, they are important because uh, in diagnosis, for the first time, if the antigens they are raised and you are going to give a treatment, if on follow up these antigens are lower or the level of these antigens decreases, you may think that, or you may be happy that the therapy is working. While if the level of these antigens they are not decreasing, that means that the therapy is not working. Secondly, if the therapy is over and in case of tumor specific antigen, there is zero level, and in tumor associated antigen, there is a normal negligible level. That means that the patient is treated of tumor after the chemotherapy or after surgery or whatever the treatment is given. After the treatment, if no antigens are seen or a lower level of antigen is seen in the patient, that means the patient is cured. But if after sometimes you again have arise in these antigen, that may give you a suspicion that there is reoccurrence of the tumor at the same site, or the patient is having some distant metastasis which is producing the same type of antigens. So this is a picture from your book. This is all what we did, that the antigens uh, which a tumor cell is expressing may be product of oncogenes or a mutant suppressor gene. It may be a mutant self protein. It may be an exaggerated protein which is not produced normally in a large amount, but it is produced in case of a tumor cell. And then there are certain oncogenic viruses which produces certain proteins. So you can see that for all these mechanisms, you have T cells producing antibodies against these antigens. So anti-tumor immunity. This is the summary what we have done till yet in case of immunity and cancer. So, in cases of certain immune cells, which are important in cancer, you have natural killer cells. Natural killer cells are going to recognize the tumor cells without any prior sensitization. Macrophages are important because they are going to act as an antigen presenting cell, just like any other microbial infection. There are helper T cells, and then there are cytotoxic T cells which are going to kill the tumor cells. Antibodies which are produced are again one of the factors which are going to kill the cell. So the target cell is killed in this type of immune system, and the cytotoxic T cells and natural killer cells are one of the important uh, component. Dendritic cells, they act as antigen presenting cell, just like macrophages. So tumor antigen is linked to a cytokine. and it is recognized by a dendritic cell. Dendritic cells are then helped by the T cells, which then can kill the cancer cell. Again, coming to the point that cancer cell or a cancer is not uh, under control of any mechanism in the body. So, yes, the immune system of our body is going to act against the cancer, but it is not enough to demolish or banish or totally eradicate that cancer. Same way, apoptosis, as we did in the first chapter, apoptosis is another important mechanism in tumors. As we said that whenever there is any abnormality in the tumors in any normal cell, it is going to get apoptosed itself. If there is any damage to the DNA, any accumulations in the cytoplasm, but in case of tumor cells, apoptosis occurs. But apoptosis alone is not enough to kill the entire tumor because of its rapid growth. Again, this is the entire summary of what we have uh, talked about the immune system and the cancer cells. So, what is immune surveillance? There is increased frequency of cancers in congenital and acquired immunodeficiency syndromes, increased susceptibility to Epstein-Barr viral infections and associated lymphomas, as we did in the viral oncogenesis. There is a selective outgrowth of antigen negative variants. That means that sometimes in a tumor, uh, there are certain tumors which are antigen negative. So they are not producing tumor antigens. So that is why the immune system is not going to recognize those antigens and not going to kill the tumor cells through production of antibodies. So a tumor act in different ways. Even a similar tumor in two persons can act in different ways. So that is why, like I told you in the initial lecture or the first lecture, that neoplasia is a vast subject, and uh, there is development of new therapies related to tumors, and immune therapy is one of the most popular upcoming therapies. So there is tumor-induced immunosuppression at last. So as we did that, tumor is growing and growing and rapidly proliferating. So it is going to suppress our own immune system. So as we say that a person having tumor is immune suppressed. So in stage 4, when the patient is having a tumor and the patient is undergoing radiation or chemotherapy, the patient is immunosuppressed. So that immunosuppressed patient may be prone to certain other infections also. So there is failure of sensitization, there is failure of apoptosis. So that is how a tumor is going to escape our immune system. So that is what a tumor is. We started with the definition of a tumor, benign and malignant. We did some etiological factors. We did how the tumor is produced. We did what are the normal and abnormal features in a cell. Now, once the tumor is developed, what are the clinical features? There are certain signs and there are certain symptoms. A patient may present with the symptom of the tissue or the organ. There is no one particular symptom of any one tumor. You can say, okay, uh, you can diagnose that tumor through that one sign or symptom. Actually, if you have hepatocellular carcinoma, it is going to uh, come up with the symptoms of liver failure. So you may have certain diagnostic tests to come up with the tumor diagnosis. So, what are the effects of tumor on the host? There are local effects in the tissue itself or the organ itself, and then there may be overall generalized effects, just like we did in the inflammation, that there are certain generalized effects in the inflammation. So, hormone production and its effect, uh, they are some generalized factors. Cancer cachexia, it is loss of appetite, poorly understood metabolic changes, production of other humoral factors. Cachexia is mostly the term we use in a patient of cancer, but cachexia can also be used in certain chronic diseases or chronic inflammatory diseases, chronic metabolic diseases. So we did this term in inflammatory processes also. So in chronic inflammatory processes, you may have cachexia just like cancer. So early cancer may not have any symptom. A cancer which is 1 centimeter in size is going to produce certain symptoms locally or generalized. So this is what you can see. A cancer in any of the organs of the tissue or a cancer metastasizing to any organ of the tissue may produce these uh, signs and symptoms. But if you notice, these are not the sign and symptoms related just to the neoplasia. These are sign and symptoms which can be related to thousands of other diseases. So, uh, in case of brain, you may see headache, vertigo, seizures, and many other pressure symptoms, respiratory cough, hemoptysis, dyspnea, lymphadenopathy, hepatomegaly, splenomegaly, or jaundice. In cases of bone fractures or pathological fracture, must raise a suspicion of a neoplasm, because pathological fractures are fractures without trauma. So if a patient is not having any history of trauma, but there is a fracture which is there for no reason, you may have a suspicion for a neoplasia. But I'm going to emphasize on the clinical aspect is that never ever jump to a diagnosis of a neoplasia on the first place. You have to first uh, rule out all the other diseases. You have to rule out the common things first. So, for example, if you have fracture, you may first keep in mind any chronic debilitating bone disease or any bone crippling disease, osteoporosis, for example, any infection in the bone, and then you may think about uh, any tumor. Same way, anywhere in the body, in any tissue or in any organ, always remember the common things first and then the tumor, because it is the doctor who is first going to diagnose and then satisfy the patient. Because if you directly raise a suspicion of cancer, the patient may be worried. What if he or she is not having such thing afterwards, after the tests or the investigations? But uh, as a word of cancer or a neoplasia is put in the mind of the person or the patient, he or she is never going to cope up with that, even if it is not a tumor, but that thing is going to stay in his or her mind. So please be very careful while diagnosing tumor. It is not that we are not going to put tumor in our differential diagnosis, but root out the common things first and then the tumors. Same way, in whenever diagnosing a tumor, always common tumors first, and then the rare variants or the rare tumors. We are going to stop here, uh, and we are going to start with paraneoplastic syndromes, and going to go into other clinical features of tumor, and then how to diagnose or investigate the cancers. So I thank you all for listening to today's lecture.